Thank you, everyone, for joining us. Welcome to this afternoon's lecture with Linda Villarosa, entitled Under the Skin, Racism as a Public Health Threat. I am Greg Mitchell, Associate Professor and Chair of Women's Gender and Sexuality Studies. It's my pleasure to be hosting Linda, and I'll introduce her formally in a moment, but I want to briefly explain the format for tonight's event. You have a Q&A function on your Zoom screen where you can submit questions via text, and you can do so at any time during the lecture. You don't have to wait until the end. No one in the audience will see those, by the way. And after Linda's talk is over, I'm going to reappear and I'll moderate the Q&A by selecting some questions to read. And I apologize in advance if we don't get to all of those questions. A recording of this lecture will be on the Williams YouTube channel if you'd like to share that with others who couldn't be here in real time. So in just a second, I will drop a link to that in that Q&A function so that you can see that. Also, Linda is also going to join us this Thursday at 4:30 p.m. for an informal follow-up conversation. That'll be a much more conventional seminar format where everyone's cameras can be on and we can actually see each other and engage in a deeper conversation about the issues from tonight's lecture. And we can still accommodate a few more people. I've got about a dozen folks who've RSVP'd, but we can still have a few more than that. And I'll be sending a Zoom link for those who do RSVP for that. So we'll also pop a link to the Google Doc where you can just put your name and email in, and I'll add you to the RSVP if you would like to seize that opportunity. So without further ado, Linda Villarosa is a contributing writer to the New York Times Magazine covering race and public health, and is a former executive editor at Essence Magazine. In 2017, her cover story, America's Hidden HIV Epidemic, was honored with an Excellence in Journalism Award by the Association of LGBTQ Journalists. That organization also inducted her into its Hall of Fame in 2020. Linda's 2018 New York Times Magazine cover story on infant and maternal mortality in Black mothers and babies was nominated for a National Magazine Award. Her essay highlighted physiological myths based on race that have endured since slavery. Linda's April 29, 2020 cover story examined race and health disparities and COVID-19 through the lens of the Zulu Social Club of New Orleans. And her August 2nd, 2020 article, The Refinery Next Door, looked at environmental justice in Philadelphia. Linda teaches journalism and Black studies at the City College of New York and is writing the book, Under the Skin, Race, Inequality, and the Health of a Nation, which will be out through Doubleday. Today's event is sponsored by the Program in Women's Gender and Sexuality Studies, the Department of Africana Studies, the Latino Studies Program, the Program in American Studies, the Davis Center, the Lecture Committee, and the W. Ford Schumann Class of 1950 Program in Democratic Studies. And I'd also like to thank Carrie Green, Veronica Bosley, and Patrick Gray for their support. But with that, I will take myself off screen and hand this over to Linda. But we'll imagine uproarious applause right now that's happening virtually for you as you take the stage, Linda.
Well, thank you so much, Greg, for having me. I'm really honored and happy to be here. I wanted to start with a thought. So this lecture is called Racism as a Public Health Threat. And about a year ago, just a little over a year ago, I did probably my final lecture or discussion of these topics. And it was a panel on maternal and infant mortality, and it was taking place, I think it was in Jackson, Mississippi. So before we got started, all the people on the panel were trying to decide what should we call it. And so the name we had was really wonky. You'll see as I talk, I'm not like that at all. So it was something like maternal mortality and infant, African-American babies and the something. And so then one of the people of the four of us said, why are we calling it this? Well, it was like discrimination among, why are we not calling it racism? And I remember thinking, I think that's a little bit much to be saying racism because we were talking to a group of mostly public health officials and healthcare providers. And I thought that's kind of aggressive. They're doing their best, whatever. And then I got shot down. The two of us who were on the non-racism thing got shot down, and we did end up calling it racism. And I was really happy. And now, a year later, that isn't even a discussion. Like, I suggested this title of racism as a public health threat because it has become so clear, given what has happened in our country with policing and Black people. I mean, it just happened, a day ago still. And given what's happened with COVID, it's very clear that there is something going on in our country that has less to do about race and more to do about racism. So I'm going to talk to you about that issue and in kind of three parts. So the first part, I'm just going to give you an overall view of racism as a public health threat. The second part, I'd like to talk to you, if there are journalists out there, I hope so. I'd like to talk to you about how I work as a journalist. I don't exactly know how other people work, but I get the feeling that the way I work is a little unconventional. So I hope that you've gotten a chance to read at least some of my stories, and I'll be referencing them as I go. So I'm going to share the screen and start with a PowerPoint. It's not too, professory, and just set you up with some background about what it means to be Black in America and how it affects health. Okay. So see how I didn't even have the racism there? I'm race, health, and inequality. That picture of that baby is Kingston Landrum. He was the baby that was the center of my maternal and infant mortality story in 2018. And he's now 2.5. So I'm really proud and happy to have been a part of his birth. So in our country, we spend more on healthcare than any other country. We spend $1,443 per person per year, which is really expensive. I looked at some other countries that are not, the so-called wealthy countries, and it's more like $500 per person per year. But what's wrong about that is, though we spend so much money, more than every other country in the world, it doesn't buy us good health. And so many of our health outcomes and our, the measures of health and wellness in our country are much, much lower, if not the lowest of every developed country, even though we spend so much more on healthcare every year. So for one, we have the highest infant mortality rate, higher than every other country, the wealthy country. So something's wrong with that. We have lower life expectancy than other countries. And this slide shows you 2017. So this is before COVID hit. Life expectancy has dropped since then. And I'll talk a little bit more about that and the racial disparities in life expectancy as we go along. The US is the only country where a woman is more likely to die in childbirth than her mother. So we're the only wealthy country where the number of women who die, and even more dramatically almost die, because the numbers are even worse, in childbirth has been rising over the past few years. When I first heard this a few years ago, I didn't believe it. I had an argument with someone because I just thought, how could this be happening in America where women are dying because of pregnancy, childbirth, and then the time after they've had a baby, which should be the happiest time in their lives? And I just didn't believe it in our country. So why? So why do we have these poor health outcomes compared to other wealthy countries? So when this question arises, it's always presented as a mystery, sort of like, how could America be spending so much money on healthcare? How could America be so wealthy, have such advanced technology in the medical field, and still be losing so many lives? But it's a mystery. Well, if it's a mystery, it's basically hiding in plain sight. It's really not a mystery. The answer is health inequality. The answer is the topic that I'm talking about today, which is racism as a public health threat or crisis. It's real, and I'm going to take you through how I see it. So for one, Black health outcomes in our country have always been lower than people of other races since we came to these shores in 1619. There's never been a time in our history where Black people have had better life expectancy. And what's interesting is in the last few years, we've been talking about sort of the opioid crisis and how life expectancy among white folks, especially poor white people, has dropped, but it's still not as low as for Black people, particularly Black men. Black babies are 2 to 3 times more likely to die than white babies. And if this racial gap did not exist, there would be 4,000 additional Black lives saved, 4,000 additional Black babies if the racial gap did not exist. And a Black woman is 3 to 4 times more likely to die related to childbirth and pregnancy and the year after than her white counterpart. So that's the story. That is the number that really struck me when I first heard about it. And it was seemed so outlandish that I didn't believe it. All right. As far as COVID, Black people are more likely to have worse cases, require hospitalization, die from it, and die at younger ages compared to whites and most others. And I think what's the most tragic for me is, looking at the statistics is to look at it and say, dying younger. So that the Black statistics, the death rate is 10 years younger than the white death rate when you look at it. And I remember looking at it, think, is this a mistake? 10 years is a lot. So it suggests that there's something, that just hits us younger. And I saw that in my own reporting, where the center of my COVID story, the person who died was a man who was 51. So he wasn't, sort of really, really old. He was only 51. Again, why? So the conventional wisdom has long been that everyone is responsible for themselves, for their own health. So if something is wrong with you, if you're dying young, if a baby dies, if a mom dies, it is your fault. You did something wrong, or something is wrong with you. So either you're doing something wrong, or something's wrong with your body and you're not taking care of yourself, or you have a genetic defect of some sort, or a genetic inferiority. So that has long been, even in science circles, less now, but certainly throughout, more often in history than not. Okay, so this blame the victim answer relies on stereotypes. So one of the stereotypes is, as far as Black people, Black culture encourages poor eating habits. Black people are sick because of lack of education. And the underlying idea is that there's a lack of self-control. So it's like, oh, you're just going to eat everything. You're going to eat this. I mean, that plate of food looks good. I want to eat it right now. But, that is the question. And it's interesting because in my stories, when I get pushback against them, it's like, well, the people in your stories weren't eating well. And one person I actually wrote back because I said, I didn't say anything about the person's eating habits. That was your assumption. I never said that. So that is just a stereotype that's been hanging around for decades, if not centuries. The other stereotype that's negative about Black women is that Black women have too many babies, ostensibly to get money from the government. So if this is the stereotype, then looking at Black infant mortality or maternal mortality, it's sort of like, well, it's your fault, you just have too many babies. And when I was writing about that baby that I showed in the first slide, several people said it's her fault because she wasn't educated and she was poor. And I wrote back again, because I said, I never said that. I never said that about that mother. And I didn't think she was uneducated. And I watched her learn as much as she could about her body. She was quite good because she had other children as well. So she knew about her body, but her legitimate concerns were ignored. The other stereotype is that Black women and men are promiscuous, have too many kids that they don't take care of. This is so vile, I'm just going to flip it along. But this is a stereotype floating around often unsaid, often dog whistled to explain especially the idea of infant and maternal mortality. Many of these stereotypes are left over from slavery. And so I was part of the 1619 project, which it was a good day today because it's being made into a book, and we just saw the book cover. It'll be out in September of this year. And but what we looked at was the effect of 250 years of enslavement, and then how the stereotypes that were left over from that terrible time still linger in today's world. And some of the ways the stereotypes linger is in false ideas about Black people, about Black bodies, and about Black culture. So the more popular suggestion is, when you see health disparities and you see health inequality, is, you know what, try harder. Just try harder. If you would just put in more effort, you would be equal. This isn't just for health, it's for wealth as well. Just if Black people would try harder, put out more effort, you wouldn't have so many problems. And so, unfortunately, this idea is not valid, does not work. More effort isn't the solution to inequality. The other thing is, I want to say as a caveat, everyone should do their best to be educated. I'm not saying that. Everybody should follow healthy habits. Nobody should be eating that giant plate of food that I showed earlier every single day. And certainly you should take care of yourself. You should be like Michelle Obama and Let's Move. Mothers should take care of their babies. We should love them up. But what if something else besides the idea of personal responsibility is going on? What if individual people are not solely responsible for ill health, and that money, we know that, doesn't always buy good health. It just doesn't work, and neither does advanced technology. The newer idea is that something about the lived experience of being Black in America is taking a toll on bodies and communities, and that the healthcare system is riddled with bias. And I'm going to just make a finer point of that and say, not out and out racism, but necessarily, but unconscious bias that shows up as racism. And what if those three things, the toll on bodies, the toll on communities, and the effect of discrimination in the healthcare system, is causing the health disparities that we see in America? These are the kind of statistics that I like to show, to say it's got to be something beyond money. It's got to be something beyond you're doing something wrong or something's wrong with your body. A Black woman with an advanced degree, like me, I have a master's degree, is more likely to die or lose her baby than a white woman with an 8th grade education. In my story about maternal and infant mortality, I wrote about my own low birth weight baby. And I was doing every single thing right. I was the health editor of Essence. I was certainly a role model for Black women's health. So for me to have a tiny little baby that fit in the palm of my hand was strange. I'm a case study of one, but statistics have also shown that Black women are more likely to die or almost die or lose a baby than a less educated white woman. So that speaks to the idea that maybe it isn't about doing something wrong, it's about something else. I think the best example to sort of prove money can't buy health is to remember what happened to Serena Williams a few years ago. Thank God her baby Olympia is fine. There she is, learning how to be a little junior Serena tennis player. But on what should have been the best day of Serena Williams's life, she went into labor with her baby. She clearly has enough money to pay for the best healthcare. If she couldn't afford it, her husband, who was, the founder of Reddit, could certainly afford it. She went into the hospital. She felt something wrong. She ended up with a C-section. Afterwards, she said something's wrong. She was having trouble breathing, and she ended up having a blood clot, which caused distress after the birth of her baby. She told the doctors what was going on. If anybody should know their body, it's her. And they ignored her legitimate concerns. She ended up getting sent home. Her C-section stitches burst. She had to go back. It turned into a huge crisis, though she was trying to tell the doctors what was happening. Her concerns were ignored. So if even Serena Williams cannot get care the way she needs, something is wrong with the system and the society. It's very interesting. About, I guess, 2 years ago, when my maternal and infant mortality story came out, I gave a lecture in a city in Minnesota at it was a small town. And the doctors of the community hospital asked me to come in and talk about my research on Black mothers and babies, infant and maternal mortality. So I gave the same spiel, kind of like what I'm saying. They argued me down so hard. First of all, they were sort of, it was the low-key lens that Black women, American women, are irresponsible and uneducated. And then several of them said, we think it's a genetic problem. Okay. So when this happens to me, I've learned to do a kind of a smackdown with medical smackdown because it's so irritating. So there's a study in 2007 that I really like. It was by two perinatologists who looked at thousands of birth certificates in Chicago. They looked at 4 categories: Black American women, Black immigrant women from some of the poorest places in the Caribbean and Africa, white American women, and white European immigrant women. So the first round, who had babies. So the first round of birth certificates, it showed that all 3 categories of babies were all basically, their weight was fine, not low birth weight, good weight. So that was the African immigrant women and from the Africa and the Caribbean, the European immigrant women, and the white American women. So then these guys were very smart. What they did is the women who had girl children, they looked, and if they had a baby, sorry, I live in New York, you can hear that siren. So they looked at the birth certificates of their children, okay? And then the second round, this is the next generation of babies, 2 categories were normal now. So now the white American women still had normal birth weight babies, mostly. The European women, now they're white American women, normal birth weight babies. And in fact, they were just a little heavier than the previous generation. The Black American women still had low birth weight babies. But now the women whose mothers were immigrants had smaller babies. They matched the African American babies. So these doctors, I don't know if they were expecting that, but what they said, I thought was profound. What they said was, for Black women, something about growing up, excuse me, in America seems to be bad for your baby's birth weight. Something about growing up here, it speaks to the idea that it's not about race or some genetic, disability or genetic inferiority that causes low birth weight babies or causes some of these health disparities, but the lived experience of being Black in America. All right, so the idea of weathering is becoming much more popular. And it was created as a theory by a professor named Arlene Geronimus at the University of Michigan. So she was looking at mainly infant mortality and was noticing that Black women's bodies seemed prematurely aged, which might have been speaking to the idea to explain why so many low birth weight babies and so many cases of infant mortality and preterm births. So what she did was she studied this phenomenon and found out that the lived experience of being Black in America was causing a kind of premature aging of the body, or an accelerated aging created by chronic stress. And chronic stress was created by high effort coping against racism, even everyday examples of discrimination and racism. So she called this phenomenon weathering. And Dr. Geronimus is a lovely person, super smart, very poetic. So she chose this term for two reasons, both because the bodies of Black people, especially Black women, were getting older. The way a storm weathers a house, it knocks the shutters off, the paint chips, the roof gets damaged, but also a house weathers a storm. So she also wanted to speak to the resilience of Black people and Black communities so that, just to say this could even be worse if we didn't have kinship and we didn't have each other. So I really appreciate this term weathering. The other idea, so one is that something about being Black in America and the high effort coping it takes to deal with racism weathers the body. The second is simply that Black communities are less healthy, and other communities of color as well are less healthy than white communities because of centuries of institutional racism. And where it stands out the most, just the most obvious, hardcore example is environmental injustice and the fact that Black people are 75% more likely to live near a facility that is creating pollution. So that alone harms the body. That alone hurts the lungs. There's also an explicit link between COVID outcomes and air pollution. We found out this last April, about just a year ago. We found this out, that link means that if you are subject to air pollution, you will have a worse COVID outcome. Black people are subject to breathing more dirty air, which at least partially explains our poor COVID outcomes. So the social determinants of health is kind of like a wonky word, but just think it's about the conditions of the environments where we live, we work, we learn, we play, and we pray. That's how I like to think of it. But those conditions are less healthy. That means we have dirtier air and water. We have lead in the pipes. We have less outdoor space to exercise in, less safe outdoor space. We have more disorganization and stress in our communities. We have fewer healthcare facilities and fewer places to buy affordable, healthy food. The third thing is simply racism in medicine. And there has been so much work done on racism in medicine that it's kind of now ridiculous to even go through it. But in a couple of, I guess in the 90s, there was a study called Unequal Treatment, and it looked at racism in medicine, and it looked at 483 previous studies. So sometimes when I talk about the idea that we receive, Black people and other people of color receive worse care, worse treatment, people argue, they're like, no, it's not that, it's not the system. And I'll say, you know what, 483 previous studies, and that was 2 decades ago. Now there's more studies. You don't need any more proof. This is a thing. This is real. When COVID happened, it just came rushing to the public eye. In the case of this woman, Dr. Susan Moore. So Dr. Moore was, I'm saying was because she passed away, was a physician in Indianapolis. So she was, practicing physician in Indianapolis. She was one of just a handful of Black women who gets a medical degree that's not that common. I think it's 2% of Black of doctors are Black women. Got her medical degree. She gets COVID. She goes to a hospital in her own city. She checks in. She is receiving such terrible care from her white physician that she complained. But she still was not receiving the proper care. And so she went on Facebook. She took a video of herself and a cry for help. She put it on Facebook. So a lot of people saw her video. I'm going to take a moment. I'm going to take a moment and share some of the video. I just want to share some of that video. I think it's really telling that you're a physician in our country. The very system that you believe in, that you work in, that raised you, cannot save you. So I'm going to take a moment. I'm going to warn you, it's sad, it's kind of harsh, but I think it's good to see. Okay, this is Dr. Moore before she was in the hospital. And this is from Democracy Now! I borrowed it. This is her video.
At that time, I'd only received 2 treatments of the remdesivir. He said, you don't need it. You're not even short of breath. I said, yes, I am. Then he went on to say, you don't qualify. I must have, because I've gotten 2 treatments. And then he further stated, you should just go home right now. And I don't feel comfortable giving you any more narcotics. I was in so much pain from my neck. My neck hurt so bad. I was crushed. He made me feel like I was a drug addict. And he knew I was a physician. I don't take narcotics. I was hurting.
What that felt like to me was a lack of empathy for this woman. And the idea that she was in such pain that she said, I'm hurting. I don't take narcotics, I'm hurting, I hurt. And that she was a doctor, was talking about the treatment. She knew the treatment she should receive and that she didn't get it. And then the kind of end of that was, this is how Black people get killed. That's what she said. This only happened a few months ago. It's new. And when she died, after she died, there was an investigation of the hospital, and the head of the hospital said part of the reason she did not get the care she needed was because she was too educated, she knew too much, and she was intimidating to some of the nursing staff at the hospital. And I think, that just makes me think, this is how Black people get killed. Being educated actually, in this case, did not help her. It made things worse. All right, I'm gonna go back to the PowerPoint. But that is heartbreaking, and that is wrong. The idea, and you heard her say, I'm hurting, and she wanted more, she wanted relief from the pain. I think it was her neck that was hurting. But Black people are much less likely in the unequal treatment that I mentioned to get proper pain medication. It's very interesting because now the idea that Black people are clearly undertreated for pain, it starts with children who break a bone or children getting their appendix or their tonsils out, and it ends with people at the end of life getting less pain management and less treatment. But I've heard people say, oh, that's good because now you're not addicted to opioids. But just because perhaps white people were getting overtreated for pain doesn't mean Black people should be in pain. But this study was in 2016. It was out of the University of Virginia, and it was a study of first year, second year, third year medical students and also residents. So the first column is just what general people think. So it found out that in general, people were confused about racial differences in Black and white bodies. But even medical students and residents believed some of the myths. The idea that Black people's blood coagulates more quickly than whites is not true. But it's surprising how many medical students who are studying the human body believe that. The idea that Black skin is thicker than white skin is not true. But look at how many people believed it. The Blacks age more slowly than white people. The idea is actually perhaps the opposite. We may be aging more quickly. The idea that, any of this stuff, but also that we have different pain tolerance is scary, because that means we're not getting the proper treatment. And these are not just physicians, these are the physicians of the future that believed these myths. And this is how Black people get killed. The false idea that Black people somehow have a super human tolerance for pain was created by Southern doctors during slavery to justify slavery, to justify torture, and that the fact that it has lingered is surprising and alarming. And I was talking to an acquaintance of mine who's a Harvard professor, and she doesn't like it when I say the myth that Black people can endure a great amount of pain, because they were not treating it as though it was a myth. The Southern doctors and scientists were treating it as fact and going to great lengths to prove it with empirical evidence that was not real. So given that something is wrong here in America, the idea that there may be premature aging for our bodies that creates poor health outcomes and early death, that our communities have been redlined, our communities have been harmed and damaged and polluted. It may be causing our early death and sickness from diseases, including COVID. And the idea that there is racism in our healthcare system means that whereas we used to say, oh, being Black, I mean, I said this, being Black is a risk factor for poor health. Race is a risk factor. But what if it isn't race? It's not race, it's racism. And that is a different issue. And that also calls for a different kind of solution. So the Black Women's Health Study was started in 1997, and it came about because there was the physicians study and the nurses health study. And these were huge long-term studies looking at people's bodies over time. But even the nurses study was something like, I think it was 97, 94, 95% white. So there were hardly any Black women in this long-term, really important study out of Boston. So some female professors and scientists at, I think it was at Boston, in Boston, created the Black Women's Health Study. I'm part of it. I got in, and so I've been answering questionnaires and part of the research. But in 1997, they started thinking, what if this isn't about the race of the person, but it's about the treatment of the person as far as racism? So they added a series of questions about racism to some of their questionnaires. And they were sort of the lighter questions, like you receive poor service than others. People act like you're not that intelligent. People think they're better than you. People think you're not really honest. But then also, have you been treated unfairly by the police in housing or at work? Of the 59,000 subjects, the women who reported the greatest experiences of racism had higher rates of preterm birth, obesity, diabetes, and other conditions. So that made a more explicit link between ill treatment and poor health. So why does this matter? Obviously it matters because it's wrong, but the other thing is, something's wrong with our country. Why do if we have such poor health compared to other wealthy countries, we can't doctor our way out of it, we can't buy our way out of it, then it creates, it's wrong, it's unfair, and it creates international shame. And it's something we really have to, if we're not looking at the solution through the right lens, because we're thinking of these old frames, then we're not ever going to solve the problem, which is a national problem. It's a Black problem, yes, but it's an American problem. Interestingly and sadly, new research suggests that it's not just Black people who are, ill treatment just doesn't harm Black bodies, it harms anyone who is being treated badly. It's just that we know more about Black people because we've been targets of discrimination over generations and generations and generations. And we've been studied more because our bodies were commodified. There's been close attention paid to the Black body because they were valuable as unpaid labor during that 250 years of forced labor and slavery. So the newer idea is that Black Americans, who we know kind of a lot about as far as racial inequality, may be the canaries in the coal mine. So thank God, hopefully most of this has passed, but we know that this isn't all over. But in the current environment where there are high expression, high level, high profile expressions of racism, sexism, anti-Semitism, homophobia, Islamophobia, anger at the poor, anger at immigrants, it may be making more and more of us ill. And here's a study that I'm very interested in. And it was in 2017, it was by Dr. Geronimus, Arlene Geronimus, the one who created Weathering, and Nicole Novak. Nicole Novak was her graduate student. So Nicole Novak was from Iowa. So she heard, the two women heard about the largest immigration raid in US history in Postville, Iowa. So it was at a meat processing plant where most of the people were immigrants from Latin America, some documented, some undocumented. So the ICE came in, they rounded up people, everyone. They created great fear, great disorganization. People were hiding in churches. Babies and children were stripped away from their parents. People were incarcerated. It was very, very scary. So doctors, Novak and Geronimus, went and looked at the birth certificates the year after the raid and compared them to the birth certificates of before the raid. And they found that among the Latinx mothers, even if they were not involved directly in the raid, their babies were 25% smaller. The white babies were the same. Even if they didn't even live in the whole, exactly in the town, the Latinx women had smaller babies the next year, partially because there was a lot of media attention and people were very, very fearful. So that raid disrupted the community, created levels of fear and stress. And what Dr. Geronimus would say is it also created this kind of accelerated aging that led to low birth weight that ultimately can raise the risk of a baby dying. So I don't want to stop this, the end of this, the last slide should not be the most negative thing ever. So I'm going to look at sort of pockets of hope. The idea that we're saying, even me, I'm saying racism is a public health crisis, it's a public health threat, is important that we're saying the words. I think growing numbers of medical students, maybe some of you are pre-med here, are wanting to do something differently. This group, White Coats for Black Lives, is at 50 medical schools around the country. And these are, we call them the woke docs, woke young docs. They are trying to make a difference. They're activist doctors. They don't want to go in with those myths that we saw on that slide from 2016. Also, the professional organizations, the agencies are saying, yes, there has been a history of racism in medicine and in healthcare, and we want to do something differently, including the AMA, which is the largest professional organization of Black physicians, of physicians in general. So I'm really happy about what has happened. I don't like that it had to come as a result of COVID. I don't like that it had to come as a result of the, murder of George Floyd and other unarmed men and women, Black men and women, but I'm glad that things are changing. So I'm gonna just talk briefly about how my process for coming up with stories. So I wanted to share how I think, and sort of the background of each story sort of is, kind of about the same thing. A lot of my stories are very similar. But I wanted to just talk to you about my first story that I did for the Times magazine, and it was on HIV/AIDS in the South. So what I do when I come up with a story idea to pitch, so I have to pitch to the Times magazine, to my editors there, I start with a number. I start with a number that I think, that doesn't make any sense. You can tell I'm pretty skeptical. So the number I heard in 2016 was that if nothing changes, Black, gay and bisexual men will, in the future, half of them will be living with HIV, which kind of in 2016, it didn't make sense. In 1996, We got, scientists created the cocktail that saved lives and also now works as prevention for HIV. So if you take HIV medication, you can lower your, the disease in your body to zero, and then you aren't infectious. And so we know that that exists. So why are men, Black men, still getting HIV? The death rates were still much higher as they had been when I first wrote the first story about what was then called GRID in 1987. I wrote another 2 more New York Times stories in 2003 about this. The death rate among Black people were elevated. Now in 2016, why is this still going on? We know what to do. What's happening? So again, the idea was, oh, Black men are promiscuous. Black men don't take care of themselves. They just aren't educated. They just need more condoms. So that was kind of the conventional wisdom, even in 2016. So I said, you know what? I want to know more. I also wanted to know, where was this story the worst? I mean, where was this these rates the worst? And I found out it was in Jackson, Mississippi. So Jackson, Mississippi had extremely high infection rate among Black gay men, and also elevated death rates. So it's like, why are people dying? So what I did was I said to the Times, I want to cover this and find out what happened, who's to blame, what's going on, and go to Jackson, Mississippi and look at the situation and see for myself. And I think it's important that, for me at least, that I see for myself. So what I did was I went to this conference called Saving Ourselves Symposium. I hate things that are called Saving Ourselves, okay? Because why do we have to save ourselves? Why is no one else helping us? Why is no one else in this country seeing these disparities and trying to change it? But okay, Saving Ourselves Symposium in Memphis, Tennessee. So I go there and I say to everyone at the conference, which is an amazing conference, it's all these Black gay men having workshops, talking among themselves, having discussion groups. I was the only journalist there. I loved it. So I started asking, if you were me and you wanted to understand why Jackson, Mississippi, of all places, has the highest rates of Black gay and bisexual men living with HIV/AIDS and dying, where would you go? And everyone said, oh, you need to meet this guy, Mr. Cedric. And I'm like, who is Mr. Cedric? And why is everyone telling me that? So they said, just go. It's only a few hours from here, drive down. So I'm super cheap. I'm kind of annoyed, but I do it. And I rent a car. I have to change my flight. That costs like $175 when you have to change a flight. I get in my little rental car. I drive down to Jackson, Mississippi. I meet Mr. Cedric, who is like a patient navigator kind of person. He worked with HIV/AIDS, people living with HIV/AIDS on the ground. He brings them medication. He drives them to clinic visits. He gets them tested. He tries to do prevention with them. He also does more. He kind of is like a father figure to them. So I spent the first time I went, I spent a week with him. And what he was doing was introducing me to men and trans women living there and telling me their stories. And because they trusted him, they trusted me. And it was really beautiful, but it was really difficult. Some of the young men, I mean, this is only a few years ago, I saw looked like 1987 when I did my first story. They were near death. Some of the men were trying to help each other. Young guys had gotten recently diagnosed with HIV, which I was one person while I was there, someone got diagnosed. Everyone was crying in the clinic. And I said, what's wrong? And they said, oh, someone just got diagnosed with HIV. So it was very hard. What I saw was that Jackson, Mississippi got left behind. It was a city that, my family's from Mississippi. So it was hard to see it with so few resources. It was hard to get anywhere. A lot of the people relied on Mr. Cedric because public transportation was so terrible to get to the clinic, to get to their jobs, to get to the support group. So what I saw was tragic and wrong. A city shouldn't be left behind like that. What I didn't see was lack of healthcare. So people had health care, they had health services. Mr. Cedric worked for My Brother's Keeper, which is an amazing clinic. They had access to HIV medication if they were infected. They had access to prevention if they weren't, but they didn't have so many resources. It was hard to get to the place. There weren't that many support groups. My editor said, I went to a club to see how, Black gay club, to see how they were handing out, information. It was really fun. It was really great. My editor said, well, why don't you, talk about the LGBTQ center there? I was like, there's no LGBTQ center. The center basically is the clinic, and the other center, the community, the hub of the community, is the club one night a week. And so if a community doesn't have resources, and if the people don't have resources, that is where a virus like HIV seeps into the cracks of the way people are living. That is what happens with COVID as well. And so when I cover these stories, what I try to do is think of a number that I don't understand, that makes me mad, that seems wrong, and then find the people on the ground who are trying to do something different, who are trying to make a difference, and who are doing things themselves. They are the Saving Ourselves Symposium and My Brother's Keeper. And one group is called, their slogan is, it's our people, our problem, our solution. I don't agree with that, but I am inspired and happy about people who are trying to do their best, making a difference, even when they don't have a lot of resources. So I'm going to stop there, and I'm very excited to hear from you and to take your questions.
Well, thank you so much for that. There are a couple of questions already in the queue. So one of them is from a person who writes, I am from Mississippi. However, I am from the more rural area of Mississippi, the Delta specifically. And I have a few questions. Why do you think places like Mississippi are left behind, besides the lack of efficient resources?
Well, I want to tell you what happened. Mr. Cedric, he's saving lives in Jackson, right? But he's from the Delta. He's from Greenville. And so, that's right in the Delta. The Delta is the poorest area of the poorest state. And so I talked to him, and he had changed jobs because his job at My Brother's Keeper was so low paid that he couldn't afford holiday gifts for his grandchildren. He's in his 50s. And so he got a new job. Then I called him just before shutdown. I went to visit him in Greenville. So he's doing the same work, but it's even more important because the resources, you're from there. There's not a lot of resources there. It's even harder to get around. He had a new car, and I was noticing the new car. I was like, this must be a lifesaver for you because, you're so much of his work was trying to get things to people and get medication to people. Also, it was so isolated where he was in the downtown area of his town. It looked like a ghost town. I think it was Greenville. It was the city where Uncle Ben's rice is made. And because I said, what's that? And he's like, oh, that's Uncle Ben's rice. You eat that rice? And I was like, oh, at least there's some kind of, jobs here. But the city was so run down. Even his little clinic was really bad. And it was good for him, but it looked not great. There just wasn't a lot of money in the community because it felt like this was a place to me, it felt like kind of the past. But also, if the resources aren't going for these poor Black communities, then they lack all the things we talked about. They lack access to healthy food. They lack, not so much outdoor space there, but they lack kind of facilities. They lack grocery stores. They lack public transportation. They lack jobs where you can really make a living. They lack, right now, they probably lack COVID testing at the beginning, for sure. And now it's harder to get vaccines to people that need them in communities that are more isolated. So, and I don't want to make it seem like, it's so negative, because when I went there, I had a great time. Spent a great time with Mr. Cedric. I went to his church. He's a deacon at his church. I wish I could drop the name, but I'm forgetting. Tiny little church. It was like, abandoned houses around it, but his church was beautiful. He took me inside. We went to the service. He was, super important there. And I was really moved by that, by, how this openly gay man was so beloved and doing such good work in the town he's from. And I think that was very moving for me.
So we have a bunch more in the queue. Here's another one from Kim. Can you explain how you might encourage others to write on and frame stories on racism and resilience in US medicine without inadvertently contributing to the deep racism, denial, and victim blaming in American medicine that you have so brilliantly illustrated? She also adds, as a side note, thank you for your incredible reporting and writing. I've taught your 2018 New York Times essay on maternal newborn mortality for a few years, and look forward to your book so that she can teach that as well.
Oh, well, thank you for that. Thank you. And it's funny because people are so sweet. They're like, would it be okay? Are there any rights issues with your? I was like, please Xerox it. Do you want me to do it? And I'll send you the copies. If you want that, I'll give you a PDF. So I like when the work gets shared. And I think, I think things are changing. I think that there are these very interesting things going on in journalism right now, in the same way that there have been changes among medical students. I've seen changes among young journalists, especially journalists of color, but a lot of young journalists. There are also a lot of fellowship programs where they're teaching some of these, issues about how to cover people and communities equitably. And I know that because I've been doing a lot of lectures at these kinds of places where I've seen, young journalists will come to me and say, will you look over my idea? Will you help me to help me with the reporting? What are the sources I should use? Because what I try to do is I try to use sources that are not the usual suspects, so to speak, just people that are doing research that is a little different, people that are from the communities. When I interview a expert, whether it's a doctor or a scientist, I will often ask, tell me how you got into the work. I know everything about Arlene Geronimus. I know a lot about a lot of the people who give me their research, because I think it's important to know where you came from as a scientist or a journalist or a physician or any healthcare provider. My background is my family came up from Mississippi, northern Mississippi and central Mississippi to Chicago, and the community where my ancestors came to is destroyed. I'm writing an essay about it. I'm working on it right now. It's on the south side of Chicago, where the greatest life gap in life expectancy is in the community where my family lived and settled, and the wealthier community 9 miles north. And so I think that people, there's a lot of research out there. There's a lot of new research. I think there's journalists who are interested in it. There are journalists who are interested in covering communities. Before I came on this lecture, I was teaching my race and media class, and I make the students look at the demographics of, the media. The deciders are still mostly older, educated white men who decide what goes on TV, what goes on the radio, what goes in newspapers. But more of us are reporters, and more of us are trying to do the work. And right now, there's a little bit more openness than there used to be about some of these ideas.
Mm-hmm. I'm going to interject one of my own questions that I have the prerogative as the host, but I will get back into our queue in a second. But I saw reporting from The Economist this week that was talking about racism in technology as it related to COVID, and specifically, I think it's called a pulse oximeter that measures the oxygen level. And as I understand it, these devices don't look at dark skin the same way, and they were actually showing inaccurate levels, higher levels of oxygen for Black people. And this was being used as a basis to determine who is going to be able to be hospitalized or not hospitalized. And so part of my question then for you is, a lot of what we were seeing in your presentation was about biases that people had, right? As in that horrifying chart that you had about the medical students and residents. But do you have thoughts on how racism is also baked into the technology that's also influencing public health in the medical field?
Well, thank you for that question. Oh, I, all right. So so yes, racism is also baked into technology. And so it's annoying when people are like, oh, if we just had more technology. Well, not if it's unfair. So here's an example that just happened to me. So I had to go to the doctor and get a full checkup. Okay. So there's this measure of your kidney function. So Black people have have more problems with kidney disease. Part of it's associated with high blood pressure. So the way I think it's called the GFR. It's like, don't ask me I'll mispronounce it if I say what it is, but I know what it looks like. So the GFR, so it measures your, the rate your kidneys filter out impurities, okay? So I myself have the test. So I get my medical test results back, and my kidney filtrate, my globular filtration rate, GFR rate for my kidney function says that that it's been adjusted because I'm Black. Okay. There's a Black rate, calculation, and a white rate. Because I'm Black, I got the Black calculation. So I'm like, wait, we don't have that's not a thing. We don't need a race correction. These race correction, and so I looked into it. The race correction for kidney function comes from how the muscles excrete a certain, substance. But the underlying assumption with the Black-white calculation is that we have more muscles or something. It's like, more musculature. So we filtrate this creatinine differently. And it's like, that's not true. I am tiny, okay? I'm sitting down, but I'm a little person. Certainly a white person who is a bodybuilder would have more muscle mass than me. Anybody would have more. So that is just incorrect. So you can't use a racial marker instead of looking at individuals. So that is just an incorrect calculation that is still going on. And what I like is that some of the medical organizations that I mentioned, the young medical students, are trying to make a difference and change that. In fact, there was a student, I think she was at the University of Washington. She asked her professor, why are we using this? This doesn't really make any sense. Why? And so she ended up getting that changed. And so by fighting back. So I like that. So now it's no longer being used, but it still is in medical books, medical student textbooks.
So we have another question. Have you in your reporting looked at cultural competence training and its impact in patient care for African-American women in particular, and BIPOC, Black, Indigenous, and people of color in general?
Yes, I have. And so thank you for asking that. I think one thing that is clear, especially as far as Black people, and I looked into it with Black mothers, in labor, and if the rates were much lower for preterm and infant mortality and infant, death, if a Black woman had a Black doctor. And so that was significant. It was recent. It was just a few months ago. I was surprised at how high, what a huge difference that made. But I think cultural competency is important. And, that is kind of like a word or sort of a phrase that is really trying to say, treat people with respect and dignity and care. When I was with Simone Landrum, I was standing there and I saw she had already reported with an earlier baby that died, and that she almost died. She was treated really badly. Her doctor kept saying, you don't have high blood pressure. When she said, I have a headache, I have swelling, my face is swollen, a lot of things. And she had a high blood pressure reading in his office because I got her medical records. He ignored her. So it ended up in tragedy. The baby that I was with, Kingston, I could see that she was being treated badly. She asked for an epidural. They asked me and the doula to leave the room. They gave her an epidural that made her too high of a dose. And she felt terrible and she complained, and they really belittled her. It was unkind. Then they treated her in a way that made it feel like, to me, that she was more like a body and not a person. Only me, who I'm a journalist there, and the doula were the ones that were really focused on her. One of the nurses were really focused on what was going on with her. She had had a tragedy before. We should be caring for her a million times better, no matter what color she is. Every single medical provider in that room was white. And so it was just sad. So I think I think whether we call it cultural competence, whether we call it attention and kindness, whether we call it focus, I think that is really important. It's also important for healthcare providers to look at their own unconscious racism, unconscious bias. And I don't mean just white ones, everyone should be looking at that, because certainly a Black healthcare provider may not feel the same about someone who's not from his or her culture, or may feel differently about someone who's not from his or her class or education status. So we all have to look at what we bring to the table that might not be positive and might affect care.
Another question. So how do you balance the reporting of news about race and the plethora of inequities associated with race with the risk of what the questioner calls trauma porn? Or, we could think about the way that we might actually re-traumatize when we see these videos and so forth. So how do you strike that balance between reporting and traumatizing?
I think that that is a hard line to walk, and I feel myself becoming increasingly careful, partially because it's traumatizing to me personally. I get tired, I get sad. I was talking to some other women who do this kind of work, long form investigations that involve sort of the public service categories. And we were talking about the importance of therapy for ourselves. I think that I try my best to be kind and careful about re-traumatizing people when I'm asking them to tell me about what happened to them. And it was hard when I did my story on the Zulu crew, and it was about COVID in New Orleans. And so I found a man so I heard about the Zulu Club which is a group of like 800 Black men in New Orleans who they throw the big parties and parades and events. And they, after Mardi Gras last year, they were dying of COVID. And so somebody said, go on their Facebook page. There's all these like little praying hands and say, pray for our brothers, or another brother got his wings. So I went to the service of one of them. It was on Zoom. And then I called and ended up interviewing his wife. So she had just buried her husband. She had watched, him slip away of a mysterious disease. She was with him. She was with him when he took his last breath. So I had to ask her to tell me that story. And I had to ask her to tell it to me more than once to make sure I got it correctly. So what I said was, I don't want my story to be the story of a bunch of dead Black men who died, who died tragically. I want my story to be the story of you and your husband and your love story, and how in the midst of this crisis, you took care of him, even though there was little hope. You took care of him, you stayed with him, you were kind, and the kindness of this group of men who are more than just the sum of their deaths. And so I talk kind of fast, and I'm certainly a Northerner at this point. So when I spoke to her, she's a Southern lady in New Orleans. I slowed way down. I took my time. I didn't interrupt. I let her tell her story how she wanted to. And so I tried to at least be kind. I tried to, not ask her to say it over and over, and just at least give her the dignity of telling me how she wanted me to hear it. So that's how I do my best. But I think that's a legitimate question that we do have to be watchful of.
Thank you. A couple more questions. Whose voices do you think health policymakers and policymakers in society need to be heard right now in this powerful moment of naming racism in public health?
I think one of the most important voices is the voices of people who have experienced it. And I had this really great experience when working on my book. So the hospital where I saw Simone Landrum be treated so badly decided to work on it. And I was funny because I was asking, why did you decide that? And she said, well, you called us out. Of course, we're going to work on it. And so they instituted this anti-racism training. And part of it was a kind of restorative justice kind of thing that they did. they brought a woman who had been really treated badly, and she was pregnant, and she went into labor very early. She went in so early that she went to labor so early that she was at huge risk of losing the baby altogether, because the baby was going to be born too small. And they told her, go home, you're not in labor. So she went home. She started bleeding. She was by herself. She was calling. There's like, nothing we can do. You're not in labor. Just go on bed rest. She went back, still denying her experience, saying you're not in labor. Finally, she had a preterm baby who has a lot of health issues to this day. Her doctor said, oh, I made a mistake. You're right. You were in labor. So she went back to that hospital. I saw it was on Zoom. She went back and told her story to the healthcare providers, some of them who were her providers, and said, this is what you did to me. And also they asked her, what can we do now to make up, that was a group of doulas who would put this on. What can we do now to make you feel that you have, like the harm has been sort of, fixed? She didn't have anything yet, but I talked to her after, and she said, I felt good that I got to confront these people and tell them what they did to me. At the same time, this hospital wasn't all bad. There was a couple of instances where there were some women who had been treated badly at another hospital. They came to this one and they got good care. And so they were also, it wasn't just, you're just horrible. It was also, sometimes you do well, but you've got to think about what may be influencing your decision-making, or, the care that you're giving. I thought that was really good, because I don't want to just talk only about what's bad and talk about, and blame institutions, especially if they're trying to do better.
So another question, although some of your previous answers have already spoken to this a bit, but maybe you'd like to add more to it. And that is, what are some systemic changes that can be made, for example, improved training of medical professionals to combat these disparities and improve the collective health of marginalized communities?
Thank you for that question, because it does speak to a future that doesn't have to look like this. I think I'm really excited about what has happened in California. So in California, had the same kind of rates of infant and maternal mortality, but especially maternal mortality as the country as a whole. So so they created what was called a perinatal quality care collaborative or something. It was like, I'm bad with, with initials and jargon like that, but it was this collaborative to look at what was going on specifically in California, where, like the rest of the country, the rates of women who died or almost died in childbirth had been rising. So they came up with all of these innovations, which made a lot of sense. So it was like, well, when a woman hemorrhages or she needs an emergency C-section, not all of the tools are available, or it's always like a big emergency crisis. Instead, it should be taken for granted, and everyone should know what to do. All the tools should be in one place, and there should be a list of protocols of what to do. So they put this into effect in hospitals. And sure enough, I think it was between 2006 and 2013, the number of women who died in childbirth dropped 55%. And by all measures, this is a success story. So you've doctored your way out of this. You've proven that, innovation really can help. However, the racial disparity didn't change at all. And most of the lives saved were white women. Most of the lives saved and almost saved were white women. So what they did was to say, well, wait a minute, maybe this isn't the answer to the racial disparities in childbirth and pregnancy. So what they did is they passed a law. I think it went into effect this year, where any healthcare provider who works with a pregnant woman or delivers a baby has to go through anti-racism training. So of some sort. So I think it's probably a work in progress, but I'm interested to see if this makes a difference, because just changing technology or putting more money to the problem didn't help. I think the other thing that I like is that medical students, the ones who want to make a difference, are really trying to. And they're saying, please, I don't want to study in a textbook that says Black people have a different kidney filtration rate. Or I don't want to have a textbook where it's like talking about, you know, not dealing with things like that oximeter that looks at skin color and not just skin. So I think that I see those changes as positive, and I see those changes as future facing, and that they should be supported.
Great. Well, I think we've actually done a good job of getting through all the questions that were in the queue. I have a few more, but I'm going to save those for Thursday. So if anybody who's out there would like to join us, do feel free to use that link or to email me, and I'll get you on that RSVP list to send you the Zoom link to continue this conversation on Thursday at 4:30 in a more intimate setting. But we will once again imagine the thunderous applause for Linda. And thank you so much for sharing your wisdom with us today. This was really, really wonderful, I think.
I want to say, I appreciate your being here. I think part of the future is just understanding that this exists, and that, you know, sometimes with my own students, I teach at a majority people of color, students of color college. And sometimes I hear them blaming themselves and the people in their communities for, you know, when I talk about this. And so I have to start from ground zero, even with ourselves. And so it's important to know that, you know, while we should take care of ourselves, while we should care about our communities and our neighbors and our friends and family, we also have to look at these systemic issues, and we can't just blame ourselves and each other, because it's the same kind of trauma that we were talking about, and it makes it worse. So I appreciate your time and your attention, and, you know, taking these, you know, these things I'm talking about seriously. You can tell I'm super into it, and I'm like, I love talking about this, and I love writing about it, and I love thinking about it. So thank you very, very much.
Well, we've loved having you. Thanks very much, and have a good night, Linda.
Thank you.